Kara McCaniel. I'm the clinical manager for the Baycrest Behavior Support Outreach Team. I welcome you today at our behavioral support rounds entitled Caring for Older Adults Living with Personality Disorder, Educational Resources to Build Skilled and Confident Care Teams. So some preliminary things to go through initially. Agnes, next slide, please. We'll start with the land acknowledgement. Although we are meeting virtually, we acknowledge that Baycrest and our related Toronto Central OH or Toronto OH behavior support program operates on the traditional territories of many Indigenous nations, which have cared for the land for thousands of years, including the Anishinaabe, Haudenosaunee, and Huron-Wendat peoples. And we recognize the current treaty holders, the Mississaugas of the Credit First Nation. This land remains home to many diverse First Nations, Inuit, and Métis people and is subject to the Dish with One Spoon Wampum, an agreement to peaceably share and care for the Great Lakes region. We are grateful to have the opportunity to work on this land today. You may live and work in different territories, so we encourage you to reflect on the land on which you are located and to consider your relationship to the land and to the people who are traditional keepers of the land. Next slide, please. Some housekeeping to go through. I'd like to review participant guidelines. This session, as you would have heard, is being recorded and will be archived on the Ontario CLRI and BSO websites. Your microphone is automatically muted. We will have about 40 to 45 minutes of presentation, followed by 15 minutes of discussion and a wrap-up. Please place any questions you have in the Q&A or chat box. If you have questions related to tech support, please message Agnes directly. You'll see her online. For those of you interested in receiving a certificate of attendance, please enter your name and email address in the completed evaluation form that you will receive afterwards. Next slide. So I'd like to introduce our presenters, Debbie Hewitt, Colborne, Emily Piraino, sorry. I practiced this in advance, I swear, and Kelly Davies. So thank you for all coming today, and I'll let them further introduce themselves.
Right, I'll just share my screen. And I'll just check that you're seeing the full slide deck. Okay, wonderful. Yes, thank you so much. We're really pleased to be here today. I'm Debbie Hewitt Colborne. I'm the project advisor for the BSO, so the Behavioural Supports Ontario Provincial Coordinating Office. I'm a nurse by background and have supported this project in my role with the Provincial Coordinating Office. And I'll hand things over to Emily and Kelly.
All right, I'm Emily Piraino. I'm the psychogeriatric resource consultant in Algoma. So I'm based in Sault Ste. Marie. I work for the North Bay Regional Health Center. I've been in this role for over 12 years, and my background is in gerontology and now studying art psychotherapy.
And good afternoon, everyone. My name is Kelly Davies, and I am the Psychogeriatric Resource Consultant for Seniors Mental Health Behavioral Support Services, Providence Care, for the Lanark, Leeds, and Grenville area, which is within the Southeast region. And I, too, am a nurse by background.
Thank you, Emily and Kelly. So we are here, but we represent other members that we'll acknowledge a little bit later from our working group and our larger knowledge to practice community of practice. So just to also recognize that that there are many that contributed to this resource that we're really pleased to share with you today. So first, just to get started, Kelly, Emily, nor myself have anything to disclose, so just wanting to recognize that. And this slide indicates how Baycrest and the behavioral support rounds mitigate potential bias. And so just they outline here the key strategies that they use to do that. But today, in terms of what we're hoping to cover, we really hope to help you discover a publicly available resource that's created for educators to engage team members in enhancing their care of older adults that live with personality disorder. And we hope that you're able to describe the impact of a capacity building initiative that utilizes various modes of delivery that benefit both the person in care and the care team. And then also just identify opportunities within your team where you might be able to benefit from this package that we're going to speak to you today about. So this is a Behavioral Supports Ontario, or a BSO initiative, and I'm certain that many of you know about BSO, but for anyone who doesn't, BSO provides behavioral health services to older adults in Ontario with or at risk of response behaviors or personal expressions related to dementia, complex mental health, substance use, and other neurological conditions. So mental health is certainly within our mandate. And on the left of the screen, you'll see a trillium that represents and has our pillars, our 3 pillars on the 3 petals. And one is which is knowledgeable care teams and capacity building. So we're very much committed in BSO to grow care teams to help them feel knowledgeable and confident and build their capacity. So this certainly fits under that pillar. And I'll hand things over to Emily.
All right, thank you, Debbie. So BSO has a knowledge to practice community of practice, so we refer to it as the COP. And this unites educators, researchers, and other knowledge translation partners from across Ontario who share a passion for capacity building and fostering knowledgeable healthcare teams for those caring for the BSO population. So I'm currently coming up to the end of my co-chair term. Some of you may attend our COP and always looking for more people who would be interested in participating. So the BSO K2P COP members collectively recognized the increase in interest and requests that were received from care teams regarding education related to mental health conditions. So because mental health is part of our mandate, and there's a lot of capacity building resources around neurocognitive disorder, we wanted to increase the focus available on mental health. So we identified an opportunity to create additional products that would build upon formal training that was already out there within the behavioral education and training supports inventory. So you may know this as the Betsy tool. So we prioritized personality disorder as our first focus for our mental health capacity building package. We will be looking to do other packages, but the personality disorder one was identified as being the one that we should focus on first. And the goal for this project was to provide educators with a grab and go, evidence-informed resource that could help build capacity within clinical teams in all sectors to skillfully and confidently care for individuals living with personality disorder and also avoiding compassion fatigue. So we knew that there was kind of 2 sides to this. So supporting the person that's living with personality disorder and really understanding why they are living in the way that they are, but also to support care team members and make sure that there's that compassion built. But also recognizing that personality disorder looks a little different in older adults and changes across age. All right, next slide. So this diagram here highlights the steps of our project. So from our COP, we established a personality disorder working group. We put it out there. Anyone who wished to join, who had a special interest in this area, was invited, and we asked people to share their resources, and we were guided by the knowledge to practice process framework. And the working group set a goal to create knowledge transfer and translation tools. So we established that our target learners with this resource would be point of care team members and leaders across all care sectors. So this was another important piece that we had identified, was making sure that we had something specific for leadership as well, that was prepared. And there were 3 themes that we had defined as being important to touch on. So understanding personality disorder, essential care and communication strategies, assessment and care planning, and then focusing on that individual and team wellness as well. We gathered information about personality disorders, and we did quite a thorough search through the literature. So we reviewed resources that were already out there from BSO partners and other educators. So handouts, slides that people were using across the province. We also completed a pretty complete literature review, looking through scholar papers, as well as consulting with specialists. So we consulted with a geriatric psychiatrist and psychologist, and then we also did receive some feedback on the final product from other specialists. Then we commissioned an artist to illustrate a fictional person who was living with personality disorder to elicit empathy through the human story. And then we were able to create the capacity building package. So we put it all together. So it's great that it has the resources, but it also follows a case. So the final package looks like this, and Kelly will speak to it more in a moment, but it consists of a background and guidelines for use, which really provides the organization with information on how to use the entire package, what the intent for each element is. We have the information booklet that's quite detailed. All of this is accessible publicly. We have slide decks that can be used, as well as tip sheets. And these were released in May of 2024, and they're all available publicly. So like I said, they're on the Brain Exchange website. So before I hand it to Kelly, I'll speak quickly to the background document. If you want to switch slides. So just quickly, this would be a simple 4-page document that provides the background information and the purpose of the package, logistical details and tips for using the package, an implementation checklist, acknowledgement to those involved in the package development as well. So really, this is key. It answers a lot of the questions around like how we got to where we were and why we decided to do this. All right, over to you, Kelly.
Okay, great. Thank you, Emily. So as Emily mentioned, the package itself includes an information booklet. So this is a 30-page booklet that really serves as a resource to educators and leaders using the capacity building package because it really takes a deeper dive into information surrounding personality disorder. So prior to facilitating the education to participants, educators and leaders can actually reference this information booklet. As a result, there may be great benefit in sharing this resource with others because of the in-depth information that it provides. It also includes a fictional case study, so a person named Randy, and really goes into the personhood information about Randy, looks at different life experiences, and takes us on a little bit of a journey. It also includes slide decks. Well, it doesn't include the slide decks. Sorry, I'll back up. The slide decks and the tip sheets that Emily referenced were in fact pulled from the information that can be found in this booklet. So we can go to the next slide, please. Looking at the slide decks themselves, there are 2 different versions. So we understand and appreciate that there isn't a lot of time when it comes to facilitating education or when it comes to people being able to attend education sessions, particularly when it comes to people working at the front line. So we have a shorter version, which includes about 15 to 20 minutes. And then we have a longer version, which is around 45 to 60 minutes. So both are very, very interactive. Each of these presentations, again, speaks to a fictional character named Randy and walks us through that journey. So looking at Randy, what was his past, what was the personhood information, and takes us on his journey of transitioning into a care home with unfamiliar surroundings and unfamiliar people. So taking us on that journey. What's interesting is not only does it validate the challenges experienced by Randy and offers a situation that can be both relatable to the participants who are taking or participating in the education, but it also acknowledges and validates the challenges that can be experienced by the staff or care providers caring for a person living with a personality disorder. So really supports that self-reflective practice, validating some of the challenges and frustrations that can be experienced by care providers, but also encourages that collaborative care approach. So regardless of the role of a care provider, everybody really has a part or a key role in the care plan or the planning phases of the person living with a personality disorder. We can go to the next slide. So In terms of the tip sheets, we have 5 tip sheets that are either 1 to 2 pages in length, and we have different topics surrounding personality disorder. So these become a really easy grab and go reference that can be either printed and distributed to participants, referenced going forward. I know that a lot of homes that I provide the education to, they actually laminate them and have them posted or easily accessible to the care providers. So when we look at the tip sheets themselves, we have essential care and communication strategies. We have setting healthy boundaries. So this particular tip sheet is actually broken into 5 specific steps when it comes to setting healthy boundaries. So the first step being stop. This is where the care provider would really take a step back and a deep breath before responding to the person living with a personality disorder, and recognizing that, what steps take place next really require that thoughtful care approach. Second step is to assess and reflect. So reflecting on the situation at hand, reflecting on the person's own response, whether or not there's any risks that are involved, reflecting on what is working, what is not working, what contributed to the situation at hand. Is there a current power struggle? Am I getting into a situation where there's more controlling language that's being used? Do I need to take a step back? Am I feeling tensions rising within myself? Those types of things. The next step would be to validate. So validate and acknowledging the feelings and emotions that the person with personality disorder may be experiencing. So for example, I see you're upset. The next step, establish a healthy boundary. So this is where we're looking at what's negotiable versus non-negotiable. Where can I be a little bit more flexible versus where I cannot be flexible because the risk is just too great. So for example, if we see that the person is upset, or we see that the person may be frustrated and maybe they're using some strong language, or they're yelling, an example would be, I see you're upset, using that validation piece. I'm going to return when you're calmer. So really looking at phrases that include you can, setting that boundary when you are, for example, calmer, as I just mentioned. And then lastly, following through to build trust. So when we say, I see you're upset, I'm going to return when you're calmer, it's really, really important that the care provider does, in fact, return to the individual, because we know quite commonly within a person with a personality disorder, there is a deep-seated, deep-rooted fear of abandonment. So really important that if we say we're going to do something, then as a care provider, we do, in fact, have to follow through to build that trust. And eventually the person will learn to anticipate our response, and that we will be returning and we will be re-engaging. So really looking at building trust. The next tip sheet is preventing team splitting. And this is actually a really helpful tip sheet in itself, because we know that as care providers, we really, really want to do a good job. We really are there to care for a person. We want the person to acknowledge our efforts, that we are trying to meet their needs. But unfortunately, if we are doing different things from one another, it can quite often lead to a lot of confusion, frustration. Everybody tends to be doing different things. So really acknowledging that, to best support the person living with a personality disorder, we really have to remain on the same page. So really walks us through, what does that look like? How can we have that constant communication, do some mini huddles, some debriefing with other members of our team to ensure that we are all on board with the plan of care going forward. There are also myths and facts, so a tip sheet around some of those common myths and facts. So each of these tip sheets, as I mentioned, can be printed and distributed as supplementary information to learners, and they really do reinforce key content that's covered within the slide decks. I myself have actually used these tip sheets for education sessions in sort of a more informal approach as a team huddle. So just sort of gathering people around, perhaps having some case-based discussions and referencing these tip sheets, which has gone over quite well. And we can go to the next slide. And I believe I'm passing it back to Emily.
Yes, thank you. So here is a quick acknowledgement to all the working group members who helped contribute to our package. So there, as you can see, there were quite a lot of people who contributed to this and shared their expertise. You can see the specialist reviewers and contributors that we worked with, and then other contributors. We just wanted to make sure that we acknowledge all of the work and expertise that went into this tool. Next slide. So what are our next steps? So we're looking at disseminating the capacity building package. We're going to be using newsletters, presentations at conferences. We did some conferences in the past as well, doing presentations for specific groups such as here. And we are collecting feedback through brief surveys, which would be available through QR codes. They're on the tools. So they're pretty easy to access to evaluate the applicability and impact of the educational resources. We're also gathering feedback and input regarding the use of the package from members of the BSO Knowledge to Practice community of practice during our regular meetings. So we are going to highlight the feedback that we've received today, and I'll pass it over to Debbie for that piece.
Great, thank you so much. So this is definitely some just preliminary results that we've had. And as Emily just said, all of the tools, so every tip sheet at the end of the slide decks and the resource manual have QR codes that learners can scan and be able just to complete a simple survey. To date, you'll see on the bottom, we've just actually had 9 that were completed. So definitely a low amount. But something we still thought was valuable in presenting today and letting you just know some of these preliminary findings. There's some reasons also that we think we have a lower amount, one of which is that this is we really think they're educational tools that are needed in the moment. So they're not necessarily what educators would pick up and do for all the areas that they support, but more so if there is a care team that's providing care for an individual living with personality disorder, that's the time that they might be reaching out to say, we're struggling with something, or we need to learn more, or that's seen by their leaders or themselves, and reach out to some educators for support. And then that's when this would be most useful, because there is a lot of reflection through the slide decks themselves around self-reflection and applied learning. So really wanting to use those adult learning principles to use them in the moment. So they may not have been used because as often as some other education that might be rolled out more comprehensively. And then we also think that perhaps our educators or people using it haven't pointed learners to the QR codes, or the learners themselves just haven't taken that next step to scan and to be able to provide feedback. But we do want to provide you with what we've gathered to date. So we had a question about how much learners, their confidence in caring for someone living with personality disorder has been impacted by the resources. It was actually a 5-point Likert scale, and so the results showed that those that answered mostly had answered as that it had improved their confidence. That's the blue on the pie chart, or green, much improved, where there were no answers about the same, worse, or much worse. So certainly seeing that people saw that it helped with their confidence. We also just, one of the questions we had on the survey was just a quick rating using a star rating out of 5 stars. And we got some great 4.8 out of 5 and how people rated the resources. Our survey also has some qualitative questions. Again, the numbers are low in what we heard, but we still thought it valuable to theme them and bring them here. So we asked learners what strategies they learned and that they plan to apply to their practice with someone living with personality disorder. And some of the themes that emerged were the importance of care planning and making sure that they care plan for those individuals, setting healthy boundaries that Kelly just spoke to, and following through to build trust as well. Again, another key concept that Kelly spoke to. We also asked the respondents what they plan to put into place to promote their own wellness when they care for someone with personality disorder. And they responded talking about self-care, about the importance of teamwork, and establishing healthy boundaries. So again, seeing some of the main themes that that are in the resources. Outside of the survey itself, we have our knowledge to practice COP educators themselves that, you know, obviously this working group came from them, but we say it's a resource built by them for them, but for other educators, other clinical leads to use as well. But we still continue to follow up with them and hear about their experiences in using these resources. So these are some quotes that we gathered over different meetings that we had with our knowledge to practice COP, and I'll just read them out to you today. But so following Randy as a person with a story throughout the resource humanizes the information. Learners are very receptive to this approach. And I used the slides and tip sheets recently, and the BSO lead really appreciated having the tip sheets to use to reinforce the key messages post-training. Great resource. I found the package very easy to use and the speaking notes detailed enough to facilitate and generate discussions with participants. I found the use of Randy as a case example to be a realistic representation of a person that long-term care team members could relate to, and often saw participants nodding in agreement with the scenarios presented. And I did 4 sessions, and the reception from staff was overwhelmingly positive. I shared the tip sheets with participants and directed them to the guide as well as the greater detailed directed them to the guide as well for greater detail regarding care planning, and this resource is amazing. So really seeing from these quotes how the different resources that, you know, have the same messaging or complement each other, how they're being used in different ways, just to continue to reinforce those messages and the key principles. So in terms of your next steps, we'd love you to download and look at the capacity building package, review the learning or the resources themselves, dive into the resource manual itself, or the information booklet, I'm sorry, just to learn if that's a learning area that you'd like to learn about. And then plan with your team and with leaders and your educators around how you might use the package. Again, probably not something that you're going to roll out as a mass education, but more so if you have team members that are caring for an individual with personality disorder, that this would be a key resource you'd go to, and who would use it, who could be the educator to roll out some of the education sessions with those PowerPoints and the accompanying tip sheets. And just having a plan in place, so when there is a reach out for such education, that your team is ready for that. And certainly to utilize it in those moments where there's a need for further capacity building around caring for individuals with personality disorder. And we just also love it if you encourage anyone using it to fill out the survey. You yourself, if you read through the information booklet, feel free to scan that QR code as well and let us know if it's been a helpful resource for yourself. So that's what we wanted to share with you today. And we're very open now to questions that you might have or comments. And I'll look to Kara just on how people do that exactly, if it's in the chat pod or in the Q&A area.
Thank you so much. So yes, now is your opportunity to start using the chat box and the Q&A to put in some questions. And I see some are coming through already. Sorry, let me just walk through this, scrolling through. So we're just sorting out, it looks like some tech issues first. So let me see if there's actual questions there.
I do see a question just about access. So yeah, they're publicly available. They are on the Brain Exchange website. Because I'm sharing my screen, it's hard for me to add it to the chat pod, but maybe Emily or Kelly, you could add the direct link to the chat pod. But certainly, yes, it is available and people can download that. Is the package translated into French? Not yet, actually. Good question. We haven't got that far, but if there's a need, we'd love to hear that as well.
I actually have a question about this population because there certainly is a rise of mental health clientele in long-term care facilities. What do you think is the most challenging aspect of working with somebody with personality disorder?
I'll look to Emily or Kelly, who are more clinically connected right now, I think, to answer some of that.
Sure. I think from my experience and just working with staff from different care homes or care environments, certainly the education piece and the knowledge piece, because it's very different than the care approach you would take with somebody living with a dementia. And I think that tends to be a real struggle for care providers because you are caring for somebody that doesn't have a cognitive impairment, whose brain isn't atrophying, or the cells aren't dying. The person is very aware of the decisions that they're making and the choices that they're making. And so I find that the staff really struggle in how to navigate that, as well as team splitting. And I sort of touched upon that very lightly. But in terms of team splitting, where the person living with personality disorder identifies, a good staff member or a favorite staff member, and they're the only one that can help me. I don't want you. You go away. You're terrible at your job. And so it becomes really tough because a lot of times staff take those comments very personally. Nobody likes to be told that they're doing a bad job, or they're not good at their job, or they're going to be reported. And so that's really tough. And, we call it team splitting because it creates a lot of frustration, angst between colleagues and team members themselves. Um, because the person that's seen as good thinks they're doing a really good job, right? And thinks, geez, I'm really good because, I'm doing things that the person really likes me to do, and I'm building this rapport, and I'm establishing trust, when in fact it's actually harming the dynamic, right? And sort of the trust between the teams. It's actually breaking the trust between the teams. So I find having a lot of conversations, doing a lot of huddles, having a lot of debriefs around that topic, and just acknowledging that everybody wants to do a good job, but it's really important to stick together as a team and have that united front.
Great, thank you. And some other questions coming through. There's one in the Q&A. Was the package co-designed with input from clients with personality disorders and or their families?
So we did talk about doing that. Unfortunately, we were not able to, but we did access resources in our literature review that were co-designed. So in a way, there was like an indirect involvement, but for the actual package that we produced, no, unfortunately.
And another question in the chat box. Do you think this resource will help reduce the stigma associated with individuals living with personality disorders? I found that in counseling, many providers would not accept a client due to the personality disorder diagnosis.
It's our hope that it reduces stigma. We actually talk about this in the guidelines for use as well as the introduction to the package. So we talk about stigma with getting a diagnosis, and also actually practitioners' hesitancy to diagnose because they know what that means for the person. So we talked a little bit about that. We talk about understanding why the person is doing this and how this is their survival strategy. So trying to promote that empathy. The personality disorder myths and facts tip sheet was also intended to help with the stigma, because certainly if the care team is having issues and they're taking things really personally, it's really hard to work effectively with that person. So we really want to work on that, but also, just like any other diagnosis, it's just a label, and everyone with that diagnosis looks so different from one another. So we really want to make that clear as well. I don't know, Kelly or Debbie want to add to that answer.
I think just in extension to what you already mentioned, Emily, using that trauma-informed approach to care, recognizing that, personality disorder really stems from a life trauma. So we know that there's been some form of trauma in the person's life, and they have developed these coping mechanisms that although aren't seen as part of the societal norm, worked well for that individual at some point. So I think really placing emphasis on that has also helped greater understanding and compassion and empathy for the person with personality disorder.
Great. And Joanna asks in the chat box, when I do education on PD with long-term care staff, I mentioned that to cure someone with a personality disorder, put them on an island on their own. Personality disorders exist on the back of the person's relationships with others and their interactions with them. Really need to have the support of the leadership teams so that staff do not feel intimidated or fearful to set limits. So not a question, but a very insightful statement. Thank you, Joanna. There was a question in Q&A. What
Can I just say, yeah, I think that just like Kelly said, I think we want to be as trauma informed as possible, and recognizing why they might have those relationships that have not been healthy necessarily. And I think that the strategies that we've set out in the information booklet and through the other educational resources really hope to equip teams to be able to have meaningful relationships with these individuals with personality disorder, but to do that in a healthy way with, you know, having a team approach that's consistent, having a care plan that's well documented, communicated so people can be consistent. And there's lots of ways to do that. And I think we're really trying to give some helpful and practical ways to do that well as a team, for the benefit of the person living with personality disorder and the team itself.
And I think something I just want to touch upon really quickly is we do have a lot of conversations within our education sessions with the staff around giving themselves permission, right? And having those conversations with leadership because it really is recognizing that this is a different approach, you know, so giving yourself permission to do something different. So I just wanted to touch upon that.
Yeah, and I'll just add to that too, is that we do talk quite a lot about what limit setting is, what's a healthy boundary, walking that middle path, because we acknowledge that sometimes staff may feel like there's either, you know, leaning into it too much or really, you know, putting up a barrier to having a relationship with that person. So how do we walk that middle ground in a healthy way? And a lot of that comes from understanding.
So in the Q&A, another question came through. What professional resources are available for clients with personality disorders? As psychiatry is the only widely available resource, yet my experience is that PD is not treated with pharmaceuticals.
Yes, so we talk about this in the resource actually. So with medication, one of the things that we found in our literature review, and it may change because things are always changing, especially in this field, but the medications are more for treating often comorbid conditions that we tend to see with personality disorder, like depression, anxiety, that might actually make the symptoms that we're seeing worse. But in terms of professional resources that are available, DBT, so dialectical behavioral therapy, is best practice. And what that program focuses on is teaching emotional regulation skills, teaching assertiveness skills, how to communicate your needs effectively, how to recognize how you're feeling in the moment. So sometimes people with personality disorders may feel emotions very intensely or may almost be cut off from them or not be able to name them. So it teaches a lot of those skills that help them to have healthy relationships. Because we know that like with borderline personality disorder, there's a lot of challenges around attachment, right? And like Debbie was saying, trauma informed, it comes from a lot of mistrust in people that they were supposed to rely on. So you can see how, especially in long-term care, that can be such a huge trigger because now you rely on everyone to do what they say they're going to do, and they're making a lot of decisions for you. So, I mean, life transitions are particularly difficult for people who are living with personality disorders, especially one where there's a lot of loss of control. So DBT, I know, is not always the easiest to access, but that would be one that I would suggest looking into. But really, I mean, any kind of psychotherapy with someone validating. So a lot of what we're teaching is, you know, it's not the emotion that's the issue, it's the response. So how do we teach the person how to communicate how they're feeling in a healthy way? So that was my long answer. I don't know if you guys want to add anything else to that.
No, that's great. I also see in the chat pod just even describing a current situation and, you know, not necessarily with a diagnosis of personality disorder, but just I think this person just seeing some behaviors that, you know, may be related to that. And so I think we also talk about that in our information booklet, just around how often there isn't a diagnosis made, and often people who have been um, living life out and may have been living more in isolation or in ways that, but maybe never had a diagnosis, and then coming into a care setting, and life changes a lot, and maybe, and the coping mechanisms that they had in place are maybe perhaps not working anymore. For whatever reason, and now they're in a care situation. So just certainly important in those situations to, I know I've seen that there are some psychiatrists on the call as well, but just the importance of a thorough seniors mental health assessment as well to see if there is a diagnosis, that being an important part of then being able to develop care strategies that are really tailored to someone who has personality disorder. Anything, Kelly or Emily, to add to that?
Okay, and then another comment came through that we had a resident that was discussed in our complex case resolution tables, and commented further, if resident completely refused to discuss her behavior or issues related to her behavior, instead gets upset to anyone, trying to mention including during care conference, what else can we do?
Sorry, I think I need clarification on the question. It's the person themselves that doesn't want to talk about the behaviors. I just wasn't clear on the question.
So, Tess Faye, if you can try using the chat box to repeat that question, and we'll get back to you. Further comments. So, I know we discussed healthy boundaries and that it can be harmful to get too close with the person. I was wondering how the care teams could balance this with a pro-attention plan, as we've seen a lot of positive outcomes from pro-attention plans in those with personality disorders who can be demanding for various things. Thank you.
And actually, in our case study of Randy, the pro-attention plan is one of the strategies. So it walks through his scenario where he's using a call bell, for example, often, and then yelling at team members as they enter and calling names. And some of the strategies are well, around setting just expectations about what a call bell is to be used for, but they also recognize that there's boredom, and they discover some of his interests and past hobbies and those kind of things, so that there's and when that happens more often, the call bell being in the afternoon, I think it is in the scenario. So actually being very, very proactive in establishing some meaningful engagement at that time, but also the team in this situation puts in a pro-attention plan. So hourly checks to check in with Randy to see how he's doing, to engage him in the things that he really enjoyed, and to have that positive rapport. And that's also, I think, just establishing a positive connection is part of it as well. And certainly in their other tip sheet around communication strategies, we do talk a lot about establishing rapport as well. There's healthy boundaries within that, but also establishing a positive and healthy rapport.
Livia commented, there is also somatic IFS and schema therapy that does a lot better job at helping someone with a PD. While DBT is great, it's not for everyone. Being open, trying different things, as it's different for every person.
Yes, and thank you for that comment. That is true. Those are also useful in personality disorder. They're not as widely studied, at least in our literature review, as DBT. I think we actually mentioned all of those in the resource. If we don't, then it did get edited out. But yeah, especially like we saw schema therapy, especially with OCPD. But the other thing is that we often see that most of the studies are on borderline personality disorder, not so much on some of the others. And we actually talk about that in the resource too, so much about like looking at what behavior we're seeing rather than the label, partially because some of them aren't as well studied, and certain, it's more the behavior patterns that you're seeing and what the person's doing. But I'm kind of going off track here, yes, there are a lot of different therapies that are used depending on what route we're looking for, and they are very helpful. So thank you for mentioning that, because we do usually typically only hear about DBT, but there's a lot out there.
I see Lexi was asking about if BSO is aware of any DBT services available to long-term care homes. I saw Haley did respond, just saying it would depend on the region. If you have an outreach team, it would be beneficial to ask them what resources are available specific to your home. I can comment, Lexi, the Baycrest BSO team, our behavior support outreach team, probably won't know about DBT services available, but maybe one of the geriatric mental health outreach teams, but certainly Debbie, Kelly, Emily, if you want to weigh in on that as well.
I think
Yeah. Oh, go ahead.
I just gonna say, I think it would be very local. So I think just reaching out to, if you have a geriatric psychiatry or seniors mental health team, to see what might be available in your local area. Emily, though, you were gonna say something too.
Yeah, basically that, and also we do mention those kinds of things, like more broadly, we don't give specific services in the resource. This was almost under the impression that a lot of the times that someone's referred to BSO, it may be more consultative in that the person maybe isn't engaging in their own care. And that can be a challenge too, right? For someone to access DBT, they need to be willing and recognizing that there is an issue, which is a challenge. And I mean, I'm in Northern Ontario. We don't really have a whole lot here available, but there might be more in the GTA.
And I was just going to say, sometimes, I know it's difficult, but sometimes if we can take a deep dive into the person's history and find out what other care partners were involved, I'm thinking specifically around ACT teams, assertive community treatment teams, because I know that some ACT team members have DBT training also, so might be worth exploring.
Excellent. It looks like Tesfaye clarified, and Joanna, hopefully, I think was able to answer your question, Tesfaye, with her response, which is great. Thank you for that, Joanna. In the Q&A, another question came through. Any suggestions for working with people with PD who have delusions and monopolize all conversations? The resident we had also used to record staff to show how their rights were violated, their perception.
I can try to answer this, but unless Kelly, did you have an experience with something like this as well? My thoughts are that I don't know so much about which delusions that care team is observing, but with monopolizing the conversation, I mean, they want someone to talk to and connect with. So maybe setting some limits around that. So setting it up so that I will spend this much time with you on this day, in this time frame. And of course, be kind to yourself, be kind to the person. Don't commit to something that's not realistic. And then at this point, like, you can, talk about whatever you want. And then at this point, we're going to need to end the conversation. You don't have to word it like that. I mean, of course, limit setting can be kind and should be kind. They also used to record staff to show how their rights were violated. So I would look at what your policies are on that and then following through with that. When I had a similar situation as this, the home had said that the person could do that. It was within their rights. This might not be uniform across the area, and this was a couple of years ago, so things could have changed. But basically it was on helping staff to feel confident in what they were doing. So making sure they're documenting, making sure they're following the care plan, because a lot of times we'll see staff get accused of things that they're not actually doing, right? They'll get accused of neglect or maybe violating staff, and the person has a right to make that accusation if that's their perception. So really it's about making sure staff are protected, and know that they're doing a good job and feeling safe within their workplace. I don't know, Kelly, do you want to add anything to that?
I've had similar experiences. So again, yeah, it really boils down to the in-house policies and procedures, specifically around in-house recordings. But yeah, that really like firm but fair approach, and setting those healthy boundaries. I think you know, the other piece to it is reinforcing those healthy interactions, right? So recognizing that if a person is upset or a person isn't being respectful, you know, to set that boundary and have confidence and give yourself permission to walk away, but also, you know, reminding the person when you're calm or when, you know, you're willing to have a calm conversation, I'm happy to come back or I'm happy to help you, and then returning. And sometimes I know that's had to, like, those steps have had to be repeated multiple times before there's actually a healthy engagement or interaction with that person. Um, Sometimes, in my experience, just in order to promote comfort within the staff and to help them feel safe in their workplace, there has been another staff that has been present, you know, when interacting with the individual. You know, sometimes, you know, that goes over well, you know, for the staff. Sometimes it's preferred not to have the second staff, especially I can appreciate how it may not be feasible to have two people interact with one person all the time, that you just may not have the availability. But it's not like both people are walking in the room at the same time. It would be one person engaging, and maybe there's one person that's sort of, you know, within earshot or within the immediate environment that can sort of act as that support person, right? So I've seen that as well.
The other thing I'd add in that is just the importance of leadership being involved, and hopefully they are in this kind of situation, that the leaders themselves are well informed about personality disorder, and the team is as well, so that you can care plan, and in the care plan things can be laid out very clearly about some of these expectations or the boundaries that are even established, so that as Kelly and Emily, Kelly and Emily said, just around helping team members to feel confident in the care that they're providing, that it's documented, but it's also supported by leadership, and that leadership is involved in having those conversations with the person as well, and just helping to navigate those really tricky waters that the situation speaks of.
I just want to add one more thing that I thought of, just as an extension to what you were saying, Debbie. I've often supported homes to use the resident bill rights, like, and be very specific about the numbered right, because it speaks to the right to refuse. It speaks to, you know, every resident has the right to live in a safe and clean environment. Because I know I had a situation where the person was keeping food items, fluids, to the point where they wouldn't let the staff remove those items, and it was becoming a high-risk situation. And so being very, very specific, using those resident bill rights and just sort of coming up with specific steps of how that was going to be addressed. And I find that helped the staff to feel very supported. And of course, leadership was on board with that. So I just wanted to add that piece.
Great, thank you. And I could see Lindsay added in some other details that are quite unfortunate, that this client with the recording, they were determined that the videos went on YouTube, Facebook, etc., because this individual was going to take down the agency, the Ministry of Long-Term Care and Ombudsman. They had one-to-one security staff as well as their own staff. It was quite a situation, I can only imagine. And the police would not help or the hospital, etc., because the person had capacity. She ran people over with her motorized wheelchair. Really, really unfortunate and quite intense. High functioning, it said as well.
Yeah, so I think, there's certainly so many, thank you for just the realities that you've presented in the chat pod, many of you. And yeah, this is why the need that for this capacity building package really surfaced, because we know that in various care settings, there's really complicated and difficult situations that are arising. And Kelly and Emily, myself, are trying to be great resources today, but we do encourage you to read through the package, and I'm sure many of you are doing the parts, the key concepts and strategies are within it, but we do hope that you'll find some additional ones and some ways that you'll be able to apply them to your complex care situations that you have, and as a team work through those together with some potential new tools and thoughts about how to do that.
Thanks, Debbie. There was another question earlier. Haley was asking, why is there so much focus on BPD, even though it's not the most common personality disorder? Is it more debilitating compared to others in general?
I'm not sure about why the research is more focused on that. It is. We see that a lot of I do know that in our resource, we really focused on we did describe the clusters very briefly, but we focused more on what behavior patterns tend to get referrals to BSO, regardless of what personality disorder label they're given, because so often, at least the ones that I've seen, it's unspecified. So we might not even know. It's more like what behavioral patterns are the staff having challenges with, and we identified all those and helped develop solutions for that. As far as the literature goes, not really sure why that's the focus. Maybe someone else has any ideas.
I'm not sure, to be honest, either, but I do know, like you said, Emily, it's more about those behavioral patterns, and as a team, what is manageable and sustainable, right? So what is sort of like your hard no? Like, where can you be a little bit more lenient? Whereas no, the risk is too great. We absolutely can't do this. And just going back to the last question or comment, just with respect to the police, I know certainly we've had similar challenges, where sort of the police comes in and maybe has, a conversation with the individual and it really doesn't go anywhere. But what we have found is helpful is having conversations in advance, so seeing the police as a care partner, having conversations, explaining sort of the scenario and what can we do, together, what would be the consequence to the action, so having those preliminary conversations sometimes has been a little bit more helpful in terms of the expectations, at least.
I see there is a hand up. Agnes, do you want to see if I think it's Lydia, yeah, there you go. Perfect. Lydia, if you want to unmute and ask your question, please. Go ahead.
Hi, thank you very much. I already typed it. I was trying to add a comment to what Debbie said in regards to residents that had a behavior. I said most of the time we have one almost the same story. It will go around. It doesn't like certain staff. It doesn't like Caucasian. It doesn't like black, or doesn't really matter. It's just who wants to give him care. We now find out that it doesn't like new staff, it doesn't like agency staff, it doesn't like blacks, certain blacks. Let's just use the word there because I'm a black woman, And at first we thought it's racist, but we kind of didn't want to put it out under the word racist, But if this is what he wants and is patient enough to wait for a person like me to come and give him care, then we said we can do that. But with the consistency is more important, because sometimes it's kind of throw tantrum. I don't want this food. It's all about food. It's all about this place is bad. It's all about he wants to get out of this place. And we now find out as we're working with him, we notice whenever he knows he's not going home on Sunday, it reacts and it turns it back to us and start giving us those behavior. So we know when the behavior is coming up on Saturday, we know something is wrong. We tell ourselves, guys, just watch out for that and, give him the support that he needs. Walking away is not the issue, but keeping quiet and say, you know what, I'll come back, we can talk. So we can plan everything. He called the cops and the cops talked to him and said, well, you call the cops, what do you want us to do for you? Because whatever is complaining everything. He will go to the management, he will go to the ED, go to everybody, but sometimes he will come back and tell you sorry. So I was just adding to Debbie to say, we not care plan that PSW should go in there two by two. Don't go by yourself, so that if anything comes, because they were scared that they're going to be fired. It's resident against the whole world. Even if we know that we are sincerely doing the right thing, if we say anything, their management is going to take it. Even before the research is frustrating for staff. So we came up that yes, go into the room, with 2 person, even if, like you said, even if that one person is doing the care, the other person is trying to clean the opposite co-room members stuff, doing stuff there, So it's really, really tough for the staff because sometimes they come back and say they are sorry. We try to keep him involved with Jehovah Witness program, which that's the only thing he can do, and we are happy that he's doing it. So the consistency with staff is very, very, very important because if he is in the dining room and he throw the cup, I don't like this food, and 20 staff acknowledge it, it keep going. So we now said, let one person acknowledge it. Okay, you don't want this food. Can you wait? What do you want? Okay, we'll talk to the kitchen staff, But if 3, 4, 5 people go, he just keep going and on and on and on. So we now find out that that really works for us. And that behavior has really calmed down and stopped so much that we couldn't even believe that what we're doing was really, really effective. So the rounds and encouraging each other to never to take it personal, because I found out that some people are taking it personal. If they say, oh, Lydia, I don't want you to give me my medication. Okay, fine, thank you. I give it to the charge nurse. The charge nurse will give the medication. And the next day is coming to look at me and say, do you want your medication? Oh, yes, oh, yes, oh, yes. If I take it personal, then I'm not going to do my work effectively. So I put that and I kind of encourage everybody. If he comes to tell you he's sorry, please do your best. He doesn't know what he's doing. It's just that 2 minutes tantrum or something that provoke him. And, that's how he can express himself. So really, this is a good topic that, majority of us really need to know and pass it on to the team, the BSO team, because it goes along where we're kind of looking at other anxiety, depression, and everything, but this personality disorder can frustrate team that people will say, no, I don't want to do it, I can resign. So I'm really saying thank you for this topic, and looking forward
Thanks,
to more
Lydia.
topics like that.
We are at time, so that's a great way to close. As you can hear, it is a hot topic and a lot of interest, so this is such a valuable resource. Please do take a look at Brain Exchange to find this resource, share it in your long-term care homes. I'd like to thank everyone for joining us today. Thank you for the 3 presenters, really, really useful content. Just a quick reminder, because I think there were some questions in the chat happening, that you will get a certificate of attendance after you complete the brief evaluation survey that will be emailed to you shortly. The recording, as you heard, will be available on the Ontario CLRI and BSO websites. Thank you again and have a great day, everyone. Stay warm. Take care.
Thank you.
Thanks,
Thank
Debbie,
you
Kelly, and Emily.
So
Take
much.
care.
Thank you
Bye-bye.
so much.
Bye.